Okay, I'm going to talk to you about some clerkship essentials for aspiring neurosurgery residents. I understand most of you are probably fourth year medical students, maybe some third year medical students as well. Um, and you're all from across Canada. Really, the target of this talk is going to be for a fourth year clerk interested in neurosurgery. And then everything I talk about is really the opinion of one neurosurgery resident at one neurosurgical training program in Ontario. Uh, and not a French program either. So I did my medical school at Western. I did a PhD at Western. I'm doing my residency at Western. So I really don't have a good grasp of what other places are sort of like. And I was part of the cohort that went through clerkship during COVID. So again, I did not have any traveling electives. So, the grain of salt you should take from this is anything I talk about is very Western biased. It may not represent fully what other programs do around the country, but hopefully you guys can take away something useful from this presentation. Um, so topics I was asked to cover include some of these things, sort of foundation in neurosurgical anatomy, some craniometric points, maybe some resources during rotations. I will talk about all these eventually. But I think what's really helpful to sort of cover is a little bit about what makes a good clerk. Some of the things that I'll outline today and talk about today include the realities of being a medical student, of going through medical school, the realities of neurosurgery residency, um, going over the clinical reasoning kind of framework we use in neurosurgery, which is a little bit different than other medical specialties or surgical specialties. It might be most similar to neurology and very different from everything else. And then I'll review some fundamental knowledge. This is heavily anatomy based. And then I'll go over some essential resources. I was told that maybe I have an hour or so for the presentation. So I'll take about 30 minutes going through these first 4 points. And then we'll leave 30 minutes for sort of questions, general discussion, other things you want me to dive into a little bit more deeply. And I think that will be probably the highest yield and what's most helpful for everybody as they move forward and look forward to their neurosurgery rotations. So I'll start off with the reality of medical school. And this is my experience in your pre-clerkship years, so your first 2 years, really very little neurosurgery is taught. You may not even get a neurosurgery selective, so a neurosurgery rotation during your core surgery rotations in your third year. So sometimes if you're interested in neurosurgery, I've seen medical students that really their first exposure to neurosurgery is the elective they go on in fourth year, just because of how things have worked out with their program. And the second reality of medical school I want to touch on is that you actually learn very little surgical skill in pre-clerkship and during your core third year surgery rotations. Um, you might be able to do some opening, closing. You might know how to retract. You may know how to suture a little bit. But my experience is that, I wasn't able to do a lot during my surgery rotations in third year, and I really got to do a lot more as the elective student on neurosurgery and other surgical disciplines when I was going through my fourth year. Of course, this might vary depending on the program you're part of. Some residents that have trained at other programs at Western now say that we actually let medical students do a lot more than they got to do as medical students. So it might vary. But let's talk about the first reality here. Because very little neurosurgery is taught in your pre-clerkship courses, you're actually not expected to have much neurosurgical knowledge as you rotate as an elective student. We would actually expect only the basics taught to you in medical school. So these are the key basics that I would expect of a good clerk, which is being able to take a thorough clinical history, so a good neurosurgical history, being able to perform a good screening neurological and spinal physical examination that's trustworthy, and being able to verbally present cases well. What I've noticed in recent years is that a lot of people, maybe because of the advent of EMRs, aren't dictating a lot anymore. A lot of clerks don't have good dictating skills, and actually being good at dictating translates directly also being good at verbally presenting cases. And that's important when, you're reviewing with staff or you're reviewing with senior resident. Really, you need to be able to verbally present a case very well. And then I take value in clerks that can document well, so documenting consultation and clinic notes well, especially the assessment and plan I go through with them. That needs to be documented thoroughly and accurately. And then knowing the basics of neuroanatomy so that you can understand the clinical reasoning that we do as neurosurgical residents and neurosurgeons. And then as a neurosurgery resident, one of the things we have to remember is that we're not only a surgeon or a medical doctor, we're, the responsible physician managing all of our ward issues and all of our admitted patients' medical issues as well. And that should be reflected in the clerks coming through. Being a good medical student also means demonstrating good general medical knowledge. Key things that we deal with all the time, septic workup, managing infections, managing hypertension, chest pain, PEs, other things like that, electrolyte abnormalities, diabetes insipidus, things that, are part of a good general internist knowledge. We actually have to know quite a bit about because our patients are generally pretty complicated. And we also have to know how to manage pain. So if you can demonstrate that you know how to manage some of these things, that is a plus when you rotate through with us. The second reality that I touched on is the very little surgical skill in your clerkship years. And as a result, again, you're not expected to have much neurosurgical skill when you rotate through with us, but we would expect some basics, and some of these basics are neurosurgical or surgical skill adjacent. Um, I would want a clerk to be meeting and examining the patient prior to an OR and to know the case. I would want them to show initiative and anticipation in the OR, help setting up the OR, whether that's imaging, setting up the Mayfield head clamp, helping to position the patient. And if you get the chance to assist, having anticipation when you're assisting is a huge plus. Helping to transfer the patient. Some places still use paper records. We do. So often, if you're able to write the OR progress note in the paper chart so that the PACU nurses and the nurses on the floor know what went on in the OR roughly, that's very helpful. And that's before, the dictation is up from the neurosurgical resident or from the staff. Some of the procedures you might get involved in as a medical student with varying levels of independence might be an external ventricular drain insertion. Some fourth year clerks that have come through have done these independently. Um, uh, I would basically not expect you to know how to do an EVD independently, but I would probably involve you in an EVD insertion, and you should know the steps and the anatomy involved and the points of a ventriculostomy. And then I would expect a fourth year medical student to come out of fourth year, especially if they're interested in neurology or neurosurgery, to be able to do an LP for the most part. The other thing that gets missed a lot is Foley's. At most institutions, I think, nursing can help put in a Foley catheter, but if they can't do it, then it falls on the resident to do it. And you're never going to be taught by a neurosurgical resident or a staff how to put in a Foley catheter. So that's a skill you should probably learn as a medical student, just as an aside. But basic things in terms of operating, I mentioned the anticipation, but being able to cut skin with a scalpel, being able to close with simple sutures. We commonly use mattress sutures, buried interrupted sutures, subcuticular sutures. And then if you're going to be in North America, knowing how to hand tie is very valuable. A lot of international places focus on instrument tying, but for some reason, North American institutions, all the staff expect you to know how to hand tie really well. Um, and then as a neurosurgical resident, just so you guys are aware, this is sort of like an outline of your neurosurgical residency. This is based on what we do at Western. This might vary a little bit across the country, but generally this is a good example. In your first 2 years, you have about 13, 14 blocks of neurosurgery. Most of your time is actually spent off service because this is part of your surgical foundations year. You have to write the surgical foundations exam. You have to get experience in other areas. Um, in the more senior years, you get a little bit more time dedicated on neurosurgery, but you still have some off-service blocks for you to consolidate your knowledge and to have time to study for examinations and that sort of stuff. If you add all of this up, you really have a total dedicated neurosurgery time of about 39 blocks. And this compared to what's expected of the from the Royal College. So these Royal College requirements is a maximum of 18 blocks in the first 2 years, and then 24 blocks of neurosurgery at minimum in sort of your middle years. And then in your senior years, additional blocks of neurosurgery may be added as decided by the program director and the residency program committee. So this means that your total neurosurgery time can vary by program and by individual. So if your residency program committee feels that you would benefit from more blocks on neurosurgery, they could add more and that sort of stuff. But I think 39 blocks is about a good estimate of the total dedicated neurosurgery time that you might spend during a neurosurgical residency. And the crazy thing about this to me is that 39 blocks is about 40 months. Here at Western, we do 7 to 8 calls per block. And if you're stringent about para rules, that means you get 7 post-call days, which means you're only on service 75% of the time because you have 1 week off per month, basically. 75% of 40 months is 30 months. 30 months is equivalent to 2.5 years. So you only have 2.5 years of residency to become a competent neurosurgeon. Obviously, we don't always take post-call days. We do have home calls, so if call's not busy, we'll stay on service and we'll be in the OR the next day, that sort of thing. And then you have plus minus. You have 40 months plus minus a little bit more or less, depending on your program. So this is a very conservative estimate of the dedicated time of residency. Probably you'll have a little bit more than 2.5 years. So because of this, you really must show as an elective student that you're a self-starter, you're easily trainable, and you can learn quickly on the job because you don't really have a lot of time to learn a very complicated field. And you also must show that you can think through a problem systematically and logically because that will help you get up the learning curve quickly. And then because your training is so condensed, you really must have a good attitude. So we expect a lot of grit, someone that has a keep your head down, sort of get the work done sort of attitude. And we feel that, those sort of people are the ones that succeed the most in a neurosurgical residency. And so if you're able to show that as an elective student, that's very helpful to you as well. There's also a separate reality of neurosurgery is that, it's quite a intense field, and it's one that has specific nuances to it that I think other surgical fields don't have. I really like this book by Paul Calanthe. I recommend that you read it if you get the chance. There's one quote here that he writes, while all doctors treat diseases, neurosurgeons work in the crucible of identity. Every operation on the brain is by necessity a manipulation of the substance of ourselves, and every conversation with a patient undergoing brain surgery cannot help but confront this fact. At those critical junctures, the question is not simply whether to live or die, but what kind of life is worth living. Because the brain mediates our experience of the world, any neurosurgical problem forces the patient and family, ideally with a doctor as a guide, to answer this question: what makes life meaningful enough to go on living? And then he also writes, learning to judge whose lives could be saved, whose couldn't be, and who shouldn't be requires an unattainable prognostic ability. And then in my opinion, it also requires a person of a certain character. And this brings me to some unteachables that would be helpful for you to have for a neurosurgical elective and neurosurgical residency and ultimately a neurosurgical career. But these are really not characteristics that can be taught. It's whether you have it or not. And sometimes we'll look for some of these characteristics. So It would be helpful to have a natural ability to be calm and professional in very difficult situations, whether with patients or families. I think good neurosurgeons have characters that are fundamentally kind and caring of both the patients and the people you are working with. And that includes cleaning staff, porters, PSWs, nurses, up the whole chain, staff and other residents. I would also want to work with someone has an easygoing personality and it's a genuine team player in what is a very difficult field. We're all stretched really thin as neurosurgical residents, so we really want someone to work with that's easygoing and will help out. And then what's really helpful is a true humility and conscientiousness, having a sense of duty and a desire to do one's work thoroughly, even though it could be work that you don't want to do. As with most things in life, 80% of the work is boring and you live for the 20% that's interesting, and that's still true of neurosurgery. Um, and a genuine interest and desire to work in neurosurgery, and we like to see that in clerks that come through. So that brings me to, the basics. So I thought since it's the first lecture, maybe in this whole series, we can sort of cover the framework that guides all of clinical reasoning in neurosurgery, which is this framework. We start always with a history and physical examination. Based on that information, we will localize the lesion and come up with a differential and a plan. As much as neurosurgery is driven by imaging nowadays, there are always cases where imaging can lead you astray, or you have conflicting information from imaging, and you need to rely on your history and physical examination to determine what the problem actually is and where you should actually operate. So history and physical examination. So the neurosurgical history. This is real basics. Maybe somebody from the crowd can tell me, what is like the components of a good neurosurgical history. You don't have to volunteer if you don't want to, but maybe someone can. That's all right. So I usually always start off with kind of detailing the past medical history. Things that are important include a neurologic history, previous neurologic conditions or surgeries, key medical comorbidities, medications. Key things to always hit are whether or not they're on any blood thinners or any medication that should be held prior to surgery, any prior adverse reactions to anesthetic and other drug allergies. Social history is actually very important as part of a neurosurgical history because a patient's baseline function and social supports are very important to know prior to commencing surgery. Um, and, a patient's functional baseline could also impact what kind of neurosurgical interventions you might offer to the patient. It's very important to clarify the substitute decision maker because oftentimes pre-op you might have someone who is intact, and then post-op you might need someone to help, make decisions. Or, if they have another complication, you always need to define a substitute decision maker or POA. Family history is important because we do have a lot of syndromic conditions. And then some of our conditions, such as vascular conditions, have a huge genetic component to it as well. And then with the history, you would focus on information that helps you localize the lesion. And we emphasize a lot at Western that you should characterize your symptoms well so that you can localize the lesion well. So that brings me to the screening neurologic examination. Anybody want to tell me what a good screening neurologic examination should cover?
Like like cranial nerves, just like gait, like just a general like sensory balance,
Hmm.
Any external, yeah, any peripheral nervous system issues that you might find, any central nervous system issues that you might find,
Mhm.
besides obviously the cranial nerves.
Yeah, so that's exactly right. Thanks, Hamza, for answering. Um, uh, I always have a very systematic approach to my own screening neurologic examination so that I don't miss anything. And if you practice this a lot, you can do a screening neurologic examination in 5 minutes or so. So it really shouldn't take you a lot of time or add a lot of time to your patient interaction. I always start off with vitals. I make sure, I assess their orientation. I check incisions and wounds. I check their language to see how much they understand or if they have any aphasia that might be impacting our interaction. Um, I always go through the cranial nerves, kind of, uh, you know, cranial nerves 2 through 12 at least. I don't usually check one. I don't know if anybody actually does. Um, Motor examination, pronator drift, quick check of strength and tone. Sensation, I generally check light touch in all four extremities, check for sensory extinction. Coordination, dysmetria, dystiadochokinesia. I'll do some deep tendon reflexes if indicated. And then gait, also examine if able. And the special tests, if you're suspecting something in the frontal lobe, frontal release signs, you might do immediate delayed recall, aspects of the MoCA, visual acuity, if you're expecting someone in the parietal lobe, Pernoud syndrome. And then if it's a VP shunt issue, for example, don't forget to check the VP shunt reservoirs to see if they refill. Um, and so I usually go through all of these categories. It takes me, basically head to toe, and it covers every aspect of the cortex and cerebellum, and it'll help me localize a lesion. So, um, in less responsive patients, of course, there's the coma examination as well. I actually, as a medical student, got asked a lot about the coma examination, because it's something I think that's glossed over in pre-clerkship often. And we're really expected to be able to do this well as neurosurgery residents. So this is a key thing that you'll probably get asked about. Who can sort of go through a coma examination and give everybody an example?
I can give this one a try, maybe.
Sure.
So things that I would look for. So basically the GCS exam, if possible. If the patient's intubated, then the language component will be left out. But other things in a patient in coma that I would consider is some of the reflexes, so oculocephalic,
Mhm.
vestibulo-ocular, maybe the what's it called, the blink reflex, these things, and some of their brainstem motor reflexes that the patient.
Perfect. Exactly. So with a coma examination, we want to see if their cortex is intact and the brainstem is intact, basically. Again, don't forget the general things. Check their vitals, including their ICP, if there's any ICP monitors inserted or EVDs inserted. Make sure you take note of any current infusions and sedating medications that could affect their examination. Check head to toe, including brainstem. So pupils, corneal reflex, cough and gag, oculocephalic. We don't usually do calorics at bedside unless we're doing a NDD. And then we'll assess the GCS. This is something you should know well prior to clerkship. They do ask this quite a lot. What are the components of the GCS and ask you to score the GCS in patients? Um, so everybody can sort of take a look at this. You know, Spontaneous eye opening would be a 4, obeying commands would be a 6 for motor, and then if they're oriented completely, would be a 5 for verbal. So the GCS spans from 3 to 15, and this is an example of what each of these findings could look like. All right, I won't belabor this too much. And then afterwards, after you've gotten the history and physical examination, that you can think through it and kind of determine the localization. Oh, sorry. one more thing that's important is you have the screening neurologic examination, but you also have a screening spinal examination for spinal issues. This also consists of a motor and sensory examination. We usually examine C5 to S1. A screening exam will consist of the pinprick sensation, again, C5 to S1. It's important to check a sensory level as well. And then part of the sensory exam should be perianal sensation also. Reflexes, it's good to check all the deep tendon reflexes so that you're covering all the myotomes. So biceps, triceps, brachioradialis, patellar ankle, and then some reflexes can give you upper motor neuron signs, so Hoffman's plantar reflex or Babinski. Some special tests, digital rectal examination, that's very important to us, especially if we're suspecting, myelopathy or Akata Aquinas syndrome, proprioception, muscle tone. Again, these are all tests that localize to different aspects of the spinal cord, the different tracts. And so making sure you cover all these areas helps you to localize a lesion in the spinal cord. So one of the things we'll also test is clonus here. But as I was saying, after you have all this information, then you want to think about localization, and localization is really based on your knowledge of neuroanatomy. I'm going to cover some basics that I would expect a clerk to be able to know, and basic systems that underlie some of the major deficits that we tend to see in our patients. So of course, the most basic thing is knowing the lobes of the brain and in general what they're responsible for. And what separates each lobe. So the frontal lobe, parietal lobe separated by the central sulcus, temporal lobe separated by the sylvian, and then the occipital lobe separated by the parietal occipital sulcus. So you have motor, sensory, auditory, speech, vision. And so those are the main areas that we think about when we try and localize a lesion. So it'd be good for you to know, and people will ask this of you. One of the main things that you need to know, I think, is identifying the central sulcus on examination and knowing where lesions are in relation to the Rolandic areas. I have a little bit of an exercise here, which is to sort of show you an approach to neuroimaging that I use, and that a lot of our residents use to be able to go through things and make sure that we describe things properly to the staff or the resident. I'm going to scroll through this image and maybe somebody can try and take me through it. I don't expect you to know how to do this, but then I'll show you how I do it. And then this could be a good learning exercise here. So maybe someone can volunteer and take me through this image here. There is an abnormality on this image, but it's a little bit subtle. So if you don't get it, it's okay. All right. Who
I
wants
mean,
to take a crack at it?
you could take a look at just what you expect from a normal anatomy, like any midline shifts, any changes in intensities, any signs of old or new bleed, any masses that you can see. I mean, maybe there's some hyperintensities I'm seeing here on the right side, perhaps. So I honestly I can't really read this, so
That's okay.
yeah.
So often when you're discussing cases, especially during rounds when they show you images, a good approach is to sort of describe the image that you see, and then describe the area that they'll center on, and then go through the anatomy. So what I would do when I look at this image, I would say, if one of my senior residents show me this, I would be saying, this is an axial MRI T1 weighted gadolinium enhanced because there's brightness within all the vessels. of the brain. As we scroll up, I don't notice any abnormalities in the posterior fossa. There's no significant midline shift. There's no ventriculomegaly. I don't notice any lesions. Coming up near the apex of the brain, I do notice some gadolinium enhancement on the right, frontal parietal cortex. And the point of this exercise is to show you where the central sulcus is. So I would probably say, these areas of enhancement appear to be lying in the right precentral and postcentral sulci, and I'll show you what I mean by that shortly. The gyri sorry, I meant to say gyri. The gyri themselves appear to be a bit expanded compared to the contralateral side. So that's sort of a systematic way to approach the imaging is describe the imaging type that you see, describe the pertinent negatives, and then try and find the pertinent positives, and then always describe the anatomical location, and then try and compare the abnormal side to the normal side in order to give you some extra information. That's a basic approach to it. And let me center on this and pause it, sorry. And then show you how to identify the central sulcus on imaging. So the central sulcus is defined by a few things. You have several signs that you can use to find the central sulcus. So you have the superior frontal sulcus that comes down and intersects with the motor strip or the precentral gyrus. So you can see on the normal side, this is the superior frontal sulcus. Let me turn on a pointer. Sorry, guys. 1 second. There we go. So this is the superior frontal sulcus. Then this must be the motor strip. And then on the contralateral side, you can see this is this superior frontal sulcus. And then this must be the motor strip here. And then there's enhancement along here and along here and here. So there's enhancement along the precentral gyrus and the postcentral gyrus. So within the Rolandic area, you can see that this must be the central sulcus here. So this is in blue on this side and this is here. Okay. And one of the signs that you can look for that people talk about is the sigmoidal hook sign or the hand knob or the omega sign. And that's sort of the hand knob here. And this is the hand knob on this side. There's also a pars bracket sign. So there's these two sort of handlebars that you can look at. And that also helps you mark where the Rolandic area is. So this would be the pars bracket sign here. And it sort of points to the postcentral sulcus and it kind of marks where your postcentral gyrus is. So I hope that's helpful. That's something that people will go through and ask senior medical students or junior residents to identify on imaging during case rounds and things like that. So if you know how to do that, you can really be impressive. And one of the major things we look for whenever there's a lesion of the brain is motor deficits or sensory deficits. And it's good to know how the motor and sensory cortex is topographically organized, which is the homunculus. So more laterally, it's tongue and face, and hand, and then leg more centrally. This is good to know as well because the vascular distributions to this cortex are different. ACA is more medially, MCA more laterally. So if you have a stroke or vascular condition, you can localize where that might be based on what you see, whether it's leg weakness or hand weakness or sensory changes to the leg or hand. Also, seizures will follow this pattern. So I'm sure all of you have heard of the Jacksonian march. It's the march of a seizure activity across this cortex according to the homunculus. So knowing this is very helpful. The other thing that will often change due to neurosurgical conditions is a person's ability to speak. So knowing the underlying kind of functional neuroanatomy that underlies speech is useful. 3 major areas of speech: Broca's area, Wernicke's area, angular gyrus, and then the major white matter tracts that are involved in speech include, the superior longitudinal fasciculus. So whenever you're operating and you see these areas, these are areas to avoid, especially if you're operating on the left side. This is relevant in procedures such as, an anterior temporal lobectomy, or if you have a lesion, say a glioma in the temporal lobe, where your entry point will be. You don't want to enter through the superior temporal gyrus where Wernicke's area is. You might want to enter a little bit lower, away from the speech centers. And as you're resecting, you want to avoid the superior longitudinal fasciculus so you don't affect speech. So when you're observing some of these surgeries, this will help you understand, what to avoid. And if you have lesions that affect any of these areas, this could help you explain why a patient might be, receptively aphasic, expressively aphasic, or globally aphasic. Another aspect that's very important is vision. So we often I actually was asked about vision a lot as a clerk. This patient has a right upper quadrant field cut. Why might that be? So it's good to know, your visual fields, general visual tracts, the visual system, the white matter tracts that are part of the visual system, and then know sort of what a lesion along the visual tracts would produce. So one of the relevant kind of tracks here would be this optic radiation. We often talk about, the Myers loop, which is this little aspect, the interior aspect of this optic radiation here. And that's very important when you're doing, say, an anterior temporal lobectomy. You don't want to go too far back and injure this Myers loop. And injuring this Myers loop, which is over here, would actually give you a upper quadrant field cut. So you often see that post-op with anterior temporal lobectomies. So that's a common finding, and you will get asked about that. But other reasons why you want to know about the visual system is because a lot of skull-based tumors, pituitary tumors, olfactory groove meningiomas, sphenoid wing meningiomas will affect some aspect of this visual system, whether that's chiasmatic or further back. And being able to know, sort of based on your history and physical examination, which aspect of the visual system is being affected is very, very helpful. And then, of course, cranial nerves, you should know some basics about this. You should know what each cranial nerve innervates and what the major findings are if one of these cranial nerves are lesioned. We often operate within the CP angle, whether it's for a functional purpose such as trigeminal neuralgia, like a microvascular decompression, or if you're operating on a skull-based tumor like an acoustic neuroma. This is something, this anatomy is something you see a lot. And then actually vascular things such as cavernous sinus syndrome, or if you have a mass compressing the cavernous sinus, that's also very good to know because that's all related to your function of your cranial nerves. So if you know your cranial nerves well and you can localize a lesion and explain your history and physical examination, that's quite impressive. And then knowing your cranial nerve anatomy also helps you when you're observing some of these procedures. Trying to turn off my laser pointer here 1 second. There we go. All right. Just a whirlwind tour of another part of the anatomy is, vascular anatomy. Vascular anatomy is quite complicated, and even neurosurgery residents have trouble with vascular anatomy, especially the more distal branches. So I wouldn't expect a clerk to know too much about vascular anatomy, but I would expect them to know, the basic circle of Willis, the major feeding arteries to the brain and cortex, and then the major vascular territories of the brain and what the consequences of a loss of flow to those vascular territories would be. So, your circle of Willis, you have, your ICAs coming up into your MCAs and ACA. You have your ACOM, your PCOM, and then you have your vertebral arteries coming up into your basilar artery. One of these verts are usually dominant, and your basilar sort of splits off into your SCAs and all of your perforators in the back there. And this is very helpful when you're looking at images of aneurysms or DSAs, knowing the circle of Willis and the major vessels here will help you identify where aneurysms lie, because they typically lie at branch points of major vessels. So that's all very helpful to know, and a good base for you to have. And knowing the vasculature is also helpful, because even outside of neurovascular surgery, you have to consider vasculature whenever you're doing any sort of operation on the brain. Sometimes you'll get CTAs for tumors. Sometimes you'll get CTAs from angiomas, for example. And you have to know what the supply is, what the draining veins are, where the major areas of danger are when you're operating. So, but I would expect a medical student only to know sort of these two things here. All right. The other thing that we deal with a lot is hydrocephalus. So the ventricular system is very simple, and something that a medical student should also know, sort of the major components of the ventricular system, and where CSF is produced, the flow of CSF, how it is absorbed, and all that physiology. So these are some slides that sort of cover that quite quickly. So I'm just trying to go through some of this quickly so we have a chance to ask questions and discuss. Okay. Now, with the spinal examination, even I still have trouble memorizing my dermatomes. Sometimes I pull out this chart to check, just to make sure I can correlate my physical examination to where I think the lesion is based on the distribution of the dermatomes. But it'd be good to memorize the distribution of the dermatomes and to memorize the major myotomes, so that you are able to do a good spinal exam and be able to, figure out what the most problematic lesion is. This is especially important in spine because you often have, multiple herniated discs. The MRI might look like there's multiple areas of severe stenosis, or that might be what the radiologist reports, or there are multiple levels of, severe foraminal stenosis, for example. But if the patient's radicular pain is in the L5-S1 distribution on the right side specifically, then you might only target that level, and you might leave the other levels alone if that is the only symptomatic level. So this is an area where I think history and physical and anatomical knowledge can really impact your surgical decision making. So this is all very good information to know. And then finally, in terms of differential, I don't have enough time, I think, to go through all of these topics, and maybe some of these will be covered in the future events. But when I went through my electives, I really just focused on this Toronto Notes chapter. This is from my copy of Toronto Notes. You can see it's from 2020. Really, Toronto Notes provides an excellent overview of common neurosurgical conditions, and actually covers a lot of the common questions asked to medical students. One of the things I didn't cover was this intracranial pressure dynamics. That's something that I was asked about a lot. So the Monroe-Kelly doctrine and all of that sort of thing, and the physiology of increased intracranial pressure. So please read this prior to your electives. And then to take it to the next level, as you go through the chapter, if you can try and organize a differential for yourself in your head based on the common locations of certain lesions, and the imaging appearance of those conditions, that can take you to the next level and really impress a resident or a staff. And then assessment and plan. Again, you're really not expected to know how to manage a neurosurgical problem because you don't get a lot of exposure as medical students. However, we want to see that you've thought about the clinical problem. Again, you should be able to verbally communicate an assessment of the patient and verbally propose a reasonable plan to me, your senior resident, or to a staff, and this should be done in a clear and logical way. You should pay close attention when the resident you are working with communicates their plan to you, and then translating the plan clearly to the documentation along with the rationale for that plan helps show that you've thought about the clinical problem. And I'm harping on this point a lot because your ability to present a case and propose a management plan verbally is evidence of your ability to solve a clinical problem sort of in your brain without writing anything down. And sometimes you need to do that, especially with the acute nature of neurosurgery. And then the notes that you write also reflect the quality of thinking and the depth of your understanding of the clinical problem. So there's really a good correlation between residents and medical students that write good notes and provide good rationale for why we are doing this plan in their note, and the quality of the resident and the medical student and the quality of their understanding and their knowledge base. So these are some metrics that we kind of like to use to determine which medical students might be stronger than others. So this is something to think about and skills to practice. And the more you can talk about something and the more you can write about something in words also helps you to refine your thinking, I think. So going through some other things. So like I said, basic procedures that you might be a part of include an external ventricular drain insertion or a lumbar puncture. Has anybody done an external ventricular drain insertion in this group? And can someone describe to me maybe the steps of this? It's okay if you don't want to. It's asking a lot.
I haven't done one, but I know there's a localization technique that you can use
Mhm.
to locate the point of entry, and then once you enter to that point, then you can access the ventricle with like a it's like a metal that's like a harder kind of like a metallic thing, and then you insert the tube with that, and then you remove the metallic part, and you're left with the tube that's kind of draining
Yeah.
the CSF. And then the point is, I think 11 centimeters if you go above the mid pupillary line. That's
Yeah.
that's that's what I understood that I had read, but I've never done it, so I might be completely off.
Uh, that's exactly correct. So I remember being asked to sort of mark out this point for an EVD just as an exercise for the resident while he was setting up. But basically, yes, we want to enter via Coker's point, which is 11 centimeters back at the mid-pupillary line. Generally, it's 11 centimeters back from the nasion or the glabella and 3 to 4 centimeters across, whether you're going on the right side or the left side. If For most people, actually, their hand, if you put in an L shape, put your tip of your index finger on the nasion and then make an L shape with your hand. Kind of the middle of your thumb is approximately where Coker's point is. The point of Coker's point is to be anterior to the coronal suture and avoid sticking your EVD through the motor cortex. Your target of your EVD is the foramen of Monroe, which is the intersection of the plane going through the external auditory meatus and down through the medial canthus. So you kind of imagine the intersection between those two planes and you aim towards that. Targeting the foramen of Monroe is what we want to do so that we're able to drain both lateral ventricles. So again, you make an incision. Some people make a longer incision. Some people make a stab incision. Then you drill a burr hole at Coker's point, and then You insert your EVD with the metal piece, which is the stylet. So the stylet helps you get through the brain. You feel a pop through the ventricle when you get to the wall of the ventricle. And then once you see CSF flowing out, then you pull out the stylet and then you advance the external ventricular catheter softly until you're about 6 centimeters at the bone. And that's generally a good depth. And then you tunnel the drain out, secure it, and attach it to the bag. You might get asked about some other points of ventriculostomy. So if you're on a pediatric neurosurgery rotation, sometimes they'll use other entry points to access the ventricles. Or if you're doing a VP shunt insertion. So it's these sort of cases that you're often a part of, is the simple cases that are for junior residents or medical students, EVDs, VP shunts. Fraser's point is one of the good ones to know. So 6 centimeters up from the inion and 3 to 4 centimeters across. And you're aiming for the contralateral medial canthus when you're inserting this. The other one is Dandy's point, which is 2 to 3 centimeters across and 3 centimeters up from the inion. And you're aiming a little bit above the glabella. And then Keen's point is used in pediatric neurosurgery a lot for VP shunt insertions, which is 3 centimeters up from the pinna of the ear and 3 centimeters posterior. So these would be good craniometric points to know. And then the other thing I want to cover is lumbar puncture. I know this is really simple stuff, but you'd be surprised. Even sometimes first-year residents aren't entirely clear to how to do a lumbar puncture, and you're often told as a first year, just go ahead and do one on your own. And you're expected to sort of know how to do this, especially if you've had an interest in neurology and neurosurgery. So key things to demonstrate is can you landmark the appropriate insertion point? Can you prep the patient properly? Can you inject local anesthetic? Are you able to self-gown and glove? We actually do our LPs as sterilely as possible here at Western, so we all gown and glove for it at bedside. And then measuring opening pressure, that's actually really finicky with all the different components, so that's something good to know and have experience with as a medical student and to show you're able to do. And good LP skills are the base for being able to do things like, lumbar drain insertions or even things like, spinal cord stimulator insertions for a functional case, for example. So, you have your superior iliac crest, marks your entry point. You can go between L3 and L4. You can go a little lower, L4, L5. Higher is usually better because there's less degenerative disease higher up. And then you sort of go at a 15-degree angle superiorly. I sometimes figure out where their belly button is and aim for the belly button. And that trick generally works. You can either go midline or you can go off midline. So you can, what we generally do is we use an 18 gauge needle. We'll go off midline, land on the lamina, and then walk the 18 gauge needle down the lamina until we get into the interlaminar space. And that way we kind of get it in every time. The 18 gauge needle allows you to have good flow, especially if you're doing a large volume tap, and also allows you to inject local anesthetic directly through the needle so that you can anesthetize the periosteum or anything that hurts. Of course, you don't want to inject local anesthetic into the dural sac, but using a larger needle that's stiffer can help in these cases. So just some tips there. Okay, the final thing is some basic surgical skills. You shouldn't be able to be proficient basically with these simple interruptive sutures, vertical mattress, intradermal sutures, and horizontal mattress sutures. These are the most common types of sutures we use in neurosurgery. So having some proficiency here, showing that you can use a fork and knife and be able to handle your instruments well is very helpful during clerkship. The other thing is the single-handed tie. So this is something that we use a lot. We kind of tie almost all of our knots with hand ties, and being able to show that you're proficient at this can really impress a staff. Key things we harp on is being able to drive the knot down with your index finger and being able to ensure the knots lay flat. Often you want to maintain tension on the suture limb you are tying around. So that's usually the limb that you're holding an instrument in or you're pulling up on. I'm right-handed, so often I'll be throwing sutures with my right hand, pulling up on the suture with my right hand and the needle driver, and then I'm tying with my left hand. So you should really be tying with your non-instrumented hand. So getting good at single-handed ties, being able to maintain tension and getting knots that are tight and lay down flat is very important and something that you'll continue to work on as a resident. All right. So that was sort of a whirlwind tour through everything. I think I took about an hour. Sorry about that. But hopefully we still have some time to have some discussion and questions. But some foundation neurosurgical anatomy, I covered it really briefly today. Some common neurological disorders in neurosurgery, I would really say read Toronto notes, and that's a very good summary of most of the things you'll encounter as a medical student. Craniometric points, like I said, we don't expect you to have much neurosurgical knowledge prior to coming to a rotation. So overall, kind of surgical corridors, craniometric points, those are low yield, but things that you'll often be a part of, which is EVD shunts, LPs, those are things that you should know the landmarks for. If you want to look more at surgical corridors, see the Neurosurgical Atlas. They've kept the articles for neurosurgical corridors free. So Neurosurgical Atlas used to be free, but is no longer. It's behind a paywall now, but the key approaches are all free with all of their diagrams and videos, and those are very useful resources as medical students and even as residents, and I'll refer to this from time to time still. Again, I didn't have time to cover a lot of this, but this is low yield. You might get more presentations on relevant anatomy for each of these subspecialties. But really, we don't expect you to know much about the subspecialties in neurosurgery, but we expect you to have good kind of a general neurologic knowledge. So maybe some other series in this, or some other lectures in this series will cover these, but not today. And then common anatomy questions asked during rounds. I try to cover the common anatomy kind of things that I used to be asked a lot of as a medical student. But really Toronto Notes has a good coverage of all of these things. Toronto Notes is very, very high yield and worth the price if you want to buy it, or if you don't, you can get it from other places. As for essential resources during rotations, things I refer to as a medical student include Toronto Notes, the Neurosurgical Atlas, and YouTube. Everything's posted on YouTube now. You can have a lot of good examples of neurosurgical procedures on YouTube. Some of the other residents in my program said they used something called Essential Neurosurgery for Medical Students, which is sort of a short 6-chapter book that covers a lot of the things you need to know as a medical student rotating through neurosurgery. So they said I should put that in there as well. Resources now that I use as a resident and things to keep an eye on if you're looking to sort of impress or get a little more in-depth reading of topics that you're interested in. Greenberg Handbook of Neurosurgery, Humans and Wynn, Schmidick and Sweet. So Humans and Wynn is more about the research, so it summarizes the evidence base. And then Schmidick and Sweet summarizes the neurosurgical techniques for all of the neurosurgical conditions. These two resources are huge volumes. I haven't even read through everything, but if you find something interesting and you want more in-depth reading, those are good starting resources. Those are good textbooks to go through. And I still use YouTube to this day to see how other people approach things and to have examples of surgeries before I go into the OR to have an idea in my mind as to what the steps of the surgeries are and how other people have done things and things to try. So hopefully that was a good whirlwind tour of some essentials of clerkship, how to approach a clerkship rotation, and characteristics of a elective student and the knowledge base of an elective student that I would expect. Um, and and hopefully that was helpful for all of you. I want to open the floor now to any questions and have a discussion and be able to add to the value and not take too much more of your time.
Awesome. Thank you very much for this comprehensive review of clerkship. So yeah, if anyone has questions, the floor is yours. Go ahead, unmute yourself, and you can ask your questions.
I have a question if that's okay.
Yeah, totally.
So you mentioned kind of like a list of things that we could do to probably make ourselves kind of stand out during the clerkship
Mhm.
experience. In terms of some of the more hands-on experiences, are there specific ways you feel like we could practice to develop those skills before we go to clerkship?
Um, like suturing or tying or that sort of stuff, or
Yeah.
yeah. So I practice with the suture pad a lot. Some of the residents that uh, were kind of talking that I had talked to as a third year or fourth year clerk suggested if you're up for it, you can get, a pig's foot or chicken wings or something like that. Chicken wings actually are pretty good because they have the skin as well as the kind of subcutaneous tissue. You can practice suturing. In terms of, getting actual practice is even on other core surgical rotations, showing initiative, earning your place in the OR, asking, hey, can I scrub in? Hey, can I do this to get actual hands-on experience? Hey, can I help close? Is that all right in this case? So doing that sort of thing will sort of get you more experience. And I think surgery is really like Um, it's not a sit back and watch kind of sport. It's sort of a dive in and try and get as much as you can kind of sport. So as a med student, if you are able to, like, I'm an introvert at heart, so it's kind of hard sometimes to initiate. But if you say, today I'm going to ask at least once to see if I can close, or I'm going to ask, to pull out a drain or and throw in a simple interrupted stitch on a real scalp um, that those things build up over time and develop the skills foundation that you need to become a good neurosurgical resident. So just keep asking and keep diving into experiences head first. That's the best way.
Thank you. I guess in case nobody has a question, I kind of want to add on to that. Do
Sure.
you find that in your experiences, preceptors and surgeons have kind of been receptive to you taking the lead on certain things during clerkship or even before clerkship, if you were doing like an observership or something like that? Did you find that they were more willing to give you opportunities if you asked for them yourself?
Yeah, I think asking shows that, you're interested and also like, is courteous. So even today, like I'm actually in Toronto for a rotation. Um, so we rotate in Toronto for radiosurgery rotation because we don't have a gamma knife machine at Western. But I've been in some of the ORs. I still ask, hey, is it okay for me to scrub in or to have a closer look? Just out of a courtesy for the staff. You shouldn't just scrub and expect that you'll be a part of a case. But if you ask, then they know you're interested and then they'll take you through things and they'll say, yes, this is a good case for you to scrub in on, or no, or yes, oh, this is the time for you to scrub in to help close. So asking kind of opens the door, and most staff are really receptive to that. Um, and at Western, we pride ourselves on allowing early independence. So we'll actually allow medical students to do a lot if they show interest. So, medical students drill burr holes. They're often first assists in the OR for simple cases. Um, but if they ask and if they showed that, they're contributing to the team, then we'll sort of reward them with that sort of experience.
Thank you.
Yeah, no worries.
I kind of had a question too.
Yeah,
You
go for it.
really emphasized being able to verbally and also just write good down, like just write good notes.
Yeah.
I just wanted to know what makes for a good verbal presenter or a good note writer. Like, what is it that you see that you're like, wow, this person knows.
If they're able to, you get a lot of, so your job as a med student and even as a first year resident is basically encompassed by the term data gatherer, right? You are taking the history and physical, you're gathering the important data for a senior resident or a staff to make a decision. So if you're able to tell me, so if you're reviewing with me, um, I don't want you to recount the entire history as the patient has told you. If you're able to kind of absorb what they have told you, lay out what the pertinent positives are, what the pertinent negatives are, and how they string together in a logical way, um, and kind of provide a story that is easy to follow, then that will help me make a decision quickly and will reduce the amount of things I have to clarify, and the amount of things on exam that I have to double check, right? Um, so that framework of thinking that I had introduced, which is history and physical localization, differential, and plan, if you're able to kind of present with that structure in mind, that's really helpful to me anyway. Um, Places vary in terms of their kind of focus of training. At Western, we kind of train neurosurgical residents like neurologists that can do surgery. So we really do emphasize history and physical a lot, and we really do emphasize localization a lot. And so if you're able to recount a brief history and recount the physical examination in a clear way, and then propose a plan with a rationale based on that history and physical, that means a lot to us. Some other places are less like that. They're maybe more surgical in their approach, where somebody else has made the diagnosis, or and your notes are a little bit shorter. So you might have to adapt to the place. But for us, if you're able to do that, that shows a good level of thinking. So I don't know if you want a more concrete example. If if I'm reviewing with someone, I would always like, okay, this is a 73-year-old female right hand dominant that presented after a fall. She's been having a lot of falls recently, has been feeling very unsteady on her feet with symptoms worsening over the last 1 to 2 weeks. Um, on physical examination, she's confused, but she doesn't have any lateralizing signs. We did get a CT head already. The CT head seems to show, obstructive hydrocephalus with transepidermal flow. I think because her GCS is, I don't know, 10, because her GCS is low, I think the best next step is to insert a external ventricular drain. What do you think about that? That's sort of an example. So pertinent positives, your history, physical, rationale, plan, right? So that would be an example of how I would go through something quickly.
Um, I guess I had a question and follow-up to that. So sometimes with like past medical history or like family history or like the medication history of the patient, there are a lot of these like nitty-gritty details that would be important if the patient were to undergo surgery, but they might not be the most important. So like when in terms of your presentation, you would kind of present those little details.
Um, I think if it's relevant to the presentation. So if they presented with a seizure, are they on any anti-epileptic medications already? If they are, what doses are they on? You know, have they had a recent medication change? Things like that. Or, if um, other medications, I typically focus on um, blood thinners. That's really, really important. So if this patient has been apixaban, what was it prescribed for? What the medical indication was? So this patient is on apixaban for atrial fibrillation. He last took it 3 days ago. If we need to do a surgery, we can, that sort of thing. Or should we wait? Um, so blood thinners and anything that is related to their presentation. Sometimes if they're super confused, you have to rule out like any other general internist, like a DIMS, right? Is there anything metabolic going on? Is there anything drug related going on? So if there's some kind of uncertainty about the patient's presentation, so if someone comes in with a fall, they have a chronic subdural, um, you know, maybe this chronic subdural is not actually of a size that should explain their symptoms. So if you're reviewing with your staff, or if you're calling medicine for consideration of admission, or you're talking to the emergency room staff, it would be good to always think about, hey, maybe they had a recent change in the blood pressure medication. I think this explains their presentation more than what we see on imaging. So it's hard to give you a concrete answer because it's so situation specific, but anything that is related to their clinical presentation, I will usually talk about.
Thank you. Any other questions from anyone else? I think in that case, we can thank Dr. Wong for their very comprehensive and the time that you spent explaining a lot of different things to us. We really appreciate all the information that you've passed on. And if anyone's interested in getting in contact with Dr. Wong personally, his contact information is on our poster.
Yeah.
Anything else, Farbot, do you want to add?
No, that's it. Thank you so much, as Nagin said, for the comprehensive review. And yeah, that's it. Thank you so much for spending your afternoon with us.
No worries. You're very welcome. If anybody wants to reach out, don't hesitate. Um, I'll try and answer your emails as much as possible, but things get busy, as you understand. Um, and then I hope this wasn't too much of a whirlwind. I went a little bit fast, but I hope it was helpful for everybody.
It was more than perfect.
All right. I will see most of you, I hope, on the CAMS tour, or as elective students coming through.
Thank you again. Have a
Thank
great
you.
night.
Bye,
Yeah.
everyone.
Bye.